Module 12, Using Translational Research in Clinical Practice. Taken as a whole, what have we learned throughout the semester? Well, many things, hopefully, including that a growing number of individuals are using alternative treatments for serious mental health problems, including depression, trauma, and autism spectrum disorders. In addition, we are moving towards the incorporation of an individual's core areas of their life, such as their religious beliefs. And these adaptations in treatments and innovations are driven by multiple factors, including dissatisfaction with current treatment, preferences for different approaches, concerns about side effects and safety, and that there's a large number of individuals that just do not benefit from existing gold standard therapies. If we look at all of the literature thus far about these mental health conditions that we've reviewed, we find that there are several promising treatments, including equine therapy for autism and trauma, ketamine and St. John's wort for depression, and that there's a growing number of studies that are coming up on the horizon, but largely these studies are underfunded compared to conventional treatments. On the flip side, there's considerations regarding emerging practice models. Many of them have completely different methodologies or are studied in a way that are not systematic. And so when we want to disseminate effective practices, we look to the literature, we may find that there are contrary evidence for their effectiveness, and part of it is, again, in how we're looking at the intervention and how we're studying it. We also know that some studies are showing no effect or mixed results or have considerable risks, such as chelation therapy for autism. Additionally, the theory for the mechanisms of change behind why some of these treatments are effective is unknown, and ketamine is probably the best example of that. The benefits of ketamine are shown to occur when it has left the body. Why is that? We just don't know. And that some of these alternative therapies may not be less expensive than conventional approaches. Equine-assisted therapy, for example, can be quite costly. Particularly, you're paying out of pocket for a lot of these treatments. They're not covered by insurance, and consequently, there's a huge cost factor to consider. When you consider the larger funding landscape, historically, efficacy and effectiveness studies are the mainstay of what is funded through the National Institutes of Health, and National Institute of Mental Health is one of those institutes under the NIH. However, NIH has been responsive. So in 1998, they founded the National Center for Complementary and Integrative Health. And I mentioned this in the module about autism spectrum disorders, that they are now looking very closely at systematically studying alternative treatments for mental health conditions. Encouragingly, in 2017, NCCIH allotted $130 million to fund research in two broad categories. The first being mind and body practices, such as acupuncture, massage therapy, spinal manipulation, as well as natural products, so herbs, botanicals, dietary supplements, vitamins, and so forth. So how do you, as an evidence-based practitioner, use this evidence to guide practice? As we mentioned earlier, the COPES model is one such way in which you can critically assess the available literature out there. Also, you would always want to be aware of and to closely consider any ethical issues that may come up through the use of these alternative therapeutic approaches. If so, how would you address them? As we talked about in Module 4, there are several ethical paradigms that you can walk through in order to identify the ethical issue and come up with a pursuable course of action. The larger landscape also needs to be a considerate. So does the treatment fit within the scope of your setting? Is there an opportunity for ongoing training and supervision in emerging therapies of interest? Is the culture and context of the organization in which you work amenable to encouraging innovative practices? And are services reimbursable? How do we move the field forward? So one way, which I've been saying practically throughout every module, is that we standardize emerging treatments. When we are testing their effectiveness across researchers, across studies, we have a standard protocol. That includes manualizing the intervention, developing fidelity measures. And fidelity measures are ways in which we can track whether the person delivering the intervention is adherent to the intervention itself, or if they've drifted. We can also test these interventions on a small scale. And as I mentioned in prior modules, there are systematic ways in which we can do small-scale testing using clinic implementation teams, which are champions for the intervention. They adapt it in a systematic way if necessary, and then they test it, evaluate the results, and come back and either change some aspect of the intervention or pilot it on a larger scale. And we need to build a research trajectory. So we need to start with especially for emerging practices where there is no evidence base, we start with an exploratory study. And then we build our research trajectory to systematically study that via efficacy and effectiveness trials. So if you recall, I think it was in Module 3, we spoke about how alternative ways to move research into practice may be to study those treatments that have been shown to be effective from a clinical perspective. So instead of a laboratory, that there's a group of clinicians that say, yes, I've seen success with intervention X. Let's test that. And then we can move on to larger studies that are more methodologically rigorous. So this slide basically is what I was just saying. There are different ways you can do this. The stage model of behavioral therapies, for example. So you pilot test the intervention first. You develop the protocol and training and develop methods of testing fidelity to the intervention. And then you move to a more rigorous level of investigation through the use of randomized controlled trials. We have to be considerate of the organizational factors that support and impede uptake. So in our investigation of a given intervention, we should be looking at the hybrid models where we can study sequentially or simultaneously implementation factors, so aspects of providers, of organizations, using this dissemination and implementation framework to really identify what are the barriers and facilitators to uptake initially and over time. So again, D&I research, dissemination, and implementation science operates from the premise that adoption must be understood within the context of interactional, internal, and external contexts. And that includes leadership. Is the leadership supportive? Providers, the organizational context, the intervention itself, and the larger external landscape. So in looking at this slide, you're like, well, what is an OSC profile? That is a measure by, again, Charles Glisson, who actually wrote his dissertation on the OSC and has made quite a career for himself by analyzing the culture and context of organizations. He then moved forward and developed an intervention, creating what he called an OATS team, which is a vertical team identified by the agency that would identify areas in which they needed to enhance either the culture or the context and adopt innovative practices. So Charles Glisson has done a lot of research in this area, but the main point is that the organizational context is a key factor in uptake and utilization of innovative practices. So Glisson's categorization of climate and culture includes how engaged that organization is, how functional, how stressful. Also, is it a rigid culture? Is it inflexible to new practices? Is it proficient? And is it resistant? The facilitating adoption of best practices model identifies 6 necessary principles for organizational utilization. So uptake of innovative practices, and that includes having the support of leadership and staff involvement, designating champions or staff that guide implementation efforts, such as Charles Glisson's OAT team that I just mentioned, offering learning communities in which organizations can come together and share their experiences about what worked, what didn't, what facilitated uptake, training and technical assistance, and building in a method of evaluation. So if you look at the green boxes, the Institute for Healthcare Improvement, as I've mentioned prior, has one such model in which they engage in a learning collaborative approach where multiple agencies come together face to face, learn about how to implement change on a small scale, test it out in their organizations, and then come back and revisit it and share stories in order for other organizations to learn effective practices. In terms of the designating champions or staff aspect, that is actually growing as an approach in the literature. So again, clinic implementation teams will do that. Lead users. So Glenn Sachs, who developed trauma systems therapy, is very interested in how, and this is borrowing from the business field, how do we run or implement an intervention? And so looking at the business field, you'll find that there are champions in the field who are heavy users or lead users. So they'll take a new software. They're the ones that will, sit out in front of a Mac store or an Apple store and wait for the newest laptop to drop. And then they'll innovate on it. So they may find ways in which they can improve on it by learning about that process, by having lead champions adopt an intervention and try to implement it and then adapt it. We can learn more about how to facilitate adoption across settings. And I wanted to end the slide deck with an example of how you can study both outcomes and implementation processes. And the 4 R's and 2 S's for strengthening families intervention, you have readings on. I'm currently leading that project in New York City, where we're trying to facilitate the uptake of this therapeutic approach across the child mental health service system. I want to draw your attention to the aims that are highlighted in blue. So in addition to looking at the impact of this intervention for children with behavior problems and their families, we're also investigating larger clinic and organizational factors, including provider perceptions of evidence-based practices, organizational support for the intervention, culture and climate upon implementation. And the 4th point is also a really innovative part of this grant. We're looking at clinic implementation teams on adapting the 4 R's and 2 S's multiple family group in a systematic way and comparing that to the standard administration. So is an adaptive model that was revised through a clinic implementation team and systematic process. Does that have longevity, or is it more likely to be adopted and sustained over time compared to the standard therapeutic approach? This study hinges on a hybrid 2 effectiveness implementation research design, and it's focusing simultaneously on both the outcomes associated with the intervention, so was it helpful in reducing child behavior problems, as well as what are the implementation factors that impede or facilitate uptake of this intervention over time.
Well, good morning, and thank you, Graham. Thank you, Bill. I was going to wish David, a happy anniversary. Thank you, Chancellor, for those remarks. It's my privilege to talk to you briefly this morning about a population of children that I care deeply about. I'm going to hopefully extend, Bill, your comments around equity and around really the serious need to meet the children that I'm going to talk with you about. And I'm also going to foreshadow the methods that we use, the research methods that we use. So that's captured in my title, It Takes a Village, of young people, parents, peers, clinicians, ourselves as academics, as services researchers, to create and develop and deliver and test new strategies to assist young people that are truly burdened by both mental health challenges, and I'm going to particularly focus in on kids that have behavioral challenges, but those drivers that help kids not be successful. David mentioned, you know, the primary ways that you as a young person develop into a healthy, functional adult is you have physical health, you have emotional wellness, you do well in school. And for way too many children that I've worked with across this nation and who live here in St. Louis, those building blocks of a healthy childhood are not lining up. As a matter of fact, they're burdened with a set of stressors and exposure to trauma. Gun violence is an important set of issues, Bill, that you and the Institute are tackling. And so I'm going to try to both highlight the needs of kids and how we pay attention to their mental health and the systems that we create to help them, but I'm also going to challenge us to do better and to create new solutions for young people so that they can be better than they are today. So I want to focus on two things. I want to focus both on young people nested within families, and I'm going to get to community as I round up the talk. And I want to orientate you to the kids that I have spent a long time. Enola used to tell me I was young once, no longer. 4 decades, really focused on kids that were burdened by poverty, that didn't have the same level of opportunities because of obstacles. Structural racism is very real, and it impacts the ability for kids to get the health care they need, the education they need. So I want to focus on those challenges, but I also want to emphasize that young people, their families, their communities have great strengths, and that we have as much a responsibility to kind of build supports and resilience as we do to address some of the mental health consequences of the burdens that we've placed on kids. So those of you that have done any clinical work, which I assume there are many in this room, this slide is going to look pretty familiar to you. We have built systems to address kids' mental health difficulties, but the set of statistics that are on this set of slides have been very stable, and now you're going to get an idea of how old I am, since I put it in my slide deck in the early 1990s. Anywhere, depending on which federal report or state report you read, that science base suggests that 2/3 to 3/4 of kids that need mental health supports will not receive appropriate supports. Rates of service use and adequate service dosage are at their lowest in poverty-impacted communities that myself and my team work in. In some ways, the areas of highest need have the lowest kind of use of services. And why is that? Because our services are plagued by a couple of things that really impact their ability to provide support and care to kids. Those things are called no-shows and early dropouts. Anybody who's done clinical care within highly stressed communities know that our service system, for every 2 appointments that a child mental health provider will schedule, one of those will be missed for some very legitimate reasons, and some lengths of stay on average for kids in poverty, 2 or 3 sessions in a mental health clinic. Now, those of you that are clinically trained know that 2 or 3 sessions, there is no magic wand to address some of the challenges that kids have. And so our system that we have set up does serve some children, but really misses opportunities to serve the many children in need. And I am sure I get scared to even say Missouri, Bill, because I know I'm going to say it wrong. But I am sure that my experiences in New York, our experiences in Chicago, I'm sure that some of this data mirrors your own experiences in St. Louis. There's a big problem with how we're reaching out to kids and families in need and whether we have the adequate supports that they need to actually address some of the challenges that they face. Now, if I'm going to present to you new solutions, I have to also say to you that this is not simple. That there's a lot of complex issues that new solutions have to take into account. And so this slide is really meant to kind of offer, as you think about creating new opportunities and supports for kids and families, these are critical considerations in our academic research literature, critical considerations in our work. We have to think about this thing around engagement. Are our services motivating, supporting, encouraging for kids and families to take advantage of? Are they capable of addressing multiple challenges and difficulties at the same time? If you have a need and you approach a clinical service, is the door open to you, or is the waiting list weeks and months long around service capacity? And then there's a set of issues that families bring to us because of the state of our world. So if you think about mental health, sometimes we clean it up, we call it behavioral health. Mental health still carries a lot of stigma, a lot of shame for our families, for our parents. As a matter of fact, we've done a lot of longitudinal studies with families in poverty, families from a range of cultural groups, a range of racial backgrounds. And in fact, when you ask families directly, if your child had a difficulty, or in some of our studies, if your child does have a difficulty, when's the right time to seek help from the mental health clinic? And the answer won't surprise you. The modal answer is as a very last resort. So those of us that went into these helping professionals, it wasn't my idea to get a social work degree to say families would like to really stay away from me if they could. But there's some reasons why families stay away from us. It has to do with the stigma, but it also has to do with the alignment, and I'm going to talk about alignment with families' values and preferences and needs and some of the things that we've created. But these are some of the things that we try to take into account as we bring people together to look at the challenges that young people and families and communities face. And as we think about new solutions, they're never simplistic solutions. They're complicated, that take into account a number of factors. So I want to actually applaud all of you that are in the child world doing academic research, because we have made tremendous progress around children's mental health and the state of prevention science, intervention science over the last set of decades. And there are whole kind of repositories from something called NREP, the National Registry of Evidence-Based Practice, Center of Disease Control, have programs that work. Scientists have really done a huge job creating an evidence base of options that really can help kids and relieve some of the behavioral health challenges that they experience. And as a matter of fact, sometimes I won't sing because I'm not a very good singer, but I sing this sometimes to a partridge in a pear tree. There's a lot of evidence. We have, in the kids' world alone, 15, this is probably 2,000 by now, published clinical trials. There's 550, maybe more, different named psychotherapies for kids. There's 50 or more randomized trials in community and home-based services, effective prevention programs. We know a lot about what can relieve the burden that kids experience based on the science. Following what we know comes a not so small gap between what we know and what we do in terms of practice, in terms of policy, in terms of funding. As a matter of fact, I am not sure that Evel Knievel could even get that car over the gap that we have between what we know and what we provide in our service sectors, particularly publicly funded service sectors that I work in, low resource service sectors, where hardworking directors and clinicians are really trying to keep up with demand, but not really able to close this gap without tremendous help, support, assistance from all of us. And so that's what I'm going to talk through the rest of the time. So that gap is coupled with a set of what I'm going to call understatements. That we as academics are disappointed because we've been all in around trying to create a science base around how to help children, how to help their families. And we're disappointed that these things don't get disseminated and embedded in our settings. And so as we've been part of both the problem, because we're the academics creating those programs, as well as wanting to be part of the solution, we've had to really understand, and this is where your Center for Implementation Research comes in, we've really had to understand those challenges and acknowledge that particularly in our early attempts to create evidence-based services for kids and families, there's been a lot of misalignment. Misalignment with what young people and family perceive themselves as needing, mismatch between the perspectives of what even a great school, the chancellor likes to say we're the top school of social work, top program of public health in the country, even a great school like ours, how we're preparing providers to practice doesn't always align with what that science base says or is supported as they go into our field settings and our first jobs. And then there's a mismatch in alignment around resources and funding and supports that are really needed to close that gap. And so if you take as a given that there is an alignment problem, then what has been at least our solution? That's been these collaborative research methods, community-based participatory research methods. They are based on a core set of assumptions that when we embed youth voice into mental health services, they become more youth acceptable, preferable, possible to engage with. When we align with families' needs, preferences, and values, those services, those new solutions become more possible for you to take advantage of. When we really listen to providers around what their families need and what they're capable of providing and come up with new solutions together, they are less rejected by providers in our settings, and so on and so on. What we hope is that by bringing people together, by bringing our consumers together, by bringing our deliverers together, that we create a new set of solutions that both help kids, but also are possible to embed and sustain within service systems. And I'm just going to give you a couple examples of our work and then turn our attention to St. Louis. So why do we need this village? Humbly, as an academic, the more education I obtained, the less intelligible I became to my mother. The way our educational system works, the skills that our journal articles kind of pull for, takes me away from the real life of families. And then in case you haven't noticed, I'm a dean, I'm a white woman, and even though I talk terribly about those 5 young adults that I raised, my life, my stressors, bear nothing in comparison to what the kids and families that we work with are up against, right? So why do we need this village? First of all, to let all of us know that child-related challenges are normative. And we haven't normalized for families that kids having mental health challenges are very common, very normal, very addressable. And anybody who's raised kids that have worried sick about the child that has failed 7th grade, is not doing their homework, is not doing what you said during adolescence. Sound familiar, parents? Challenges with kids are normal, and we needed our village to remind us of that. We need our village to enhance receptivity, decrease stigma, but also breathe life. And this is a picture of our community collaborative board that works on a number of our mental health projects, both in New York and then across the country. So I'm just going to focus on one collaboratively designed service program that we embedded. You're right, Bill. I at some point got very tired of just doing small trials. So we took on the whole state of New York with this program, and so I'm going to talk a little bit about what that was like. But first I want to talk to you about what's an example of a collaborative new solution for kids. And I'm going to talk specifically about work that we did for multiple family groups. And we focused kids and families coming together in child mental health clinics, first in New York City, around the most common reason that kids get referred to mental health programs. They get in trouble. The modal child who is referred, even right now in St. Louis, is going to be an elementary or early junior high child, and they're going to have done a beautiful thing. They have called attention to their pain by behaving badly. They've annoyed the adults around them. Most common way that kids get to our services, if missed, by the time kids enter junior high and high school, they will no longer be service recipients. And many, many of the kids that we want to touch do hit our child mental health system at some point. So that's where we focused our multiple family group effort, really bringing kids and families together to address kids' conduct difficulties. And we created an intervention protocol, a set of meetings that kids and families would work through together in a clinic facilitated by providers that really helped to do a couple of things, and this is the theme of the conference, Bill, to build resilience in families, to build strengths. Because the science says to us that in order for kids to be behaviorally successful, their families have to be strong, they can't experience too much stress, they have to have enough support that they can actually really do their job of parenting. And so that's what multiple family groups were supposed to build. They were not supposed to target, you're a bad family because you have a kid who behaves badly, you need parenting remediation. No, in many of our cases, parents were really parenting and had the world working against them. And we needed to build strengths and support families so that their kids could be more behaviorally successful. Why was that important? The same way your grandmother told you, little kids, little problems, big kids, big problems. We needed to hang on to kids and families when they first touched the system so that we could help families do their job so that kids could be more behaviorally successful. So the first trial of this multiple family group approach, bringing kids and families together, we targeted kids 7 to 11. Remember I told you that early elementary, early junior high school, they met diagnostic criteria for serious behavioral difficulties. These kids were seriously challenged in terms of their behavior. The vast majority of the kids that were in this particular NIMH-funded trial were African American and Latino. I'll show you a little bit about their average income, very, very low for New York City. And so as we put together this kind of protocol around how could we take the science but also address stigma and address engagement and address problems that parents experienced and kids, there was a lot of contribution around the content of what went into this intervention and the process of delivery. So what's a multiple family group? Its primary aim is to reduce kids' conduct problems, informed by lots of research, developed to provide an opportunity for parents and kids to share information, address common concerns, meaning this is normal to have common concerns, create supportive networks, and address service capacity. So in this particular intervention, if you were a kid with conduct difficulties, you could rate in New York City, I know nobody's supposed to have a waiting list, you could wait anywhere from 2 months to 6 months to get an appointment. And so that's why we chose with the clinic providers, with the directors, to work in groups as opposed to individually. So this is the literature. So those of you that are working with kids with conduct difficulties right now, this actually is a pretty good summary of the existing academic literature about the ways that parents and families can help kids be more behaviorally successful. Parenting skills matter. The communication channels you set up in your family matter. The supportive environment. Do you have any trouble over Thanksgiving creating a supportive family environment? This is hard stuff, right? But the literature is really clear. If families can parent well enough, if they can create enough open lines of communication, if they can create positive parent-child interactions, incredibly important. The evidence base, though, is tricky, because when you look at some of the first and second generation of evidence-based practices and you dig into those method sections, the families that drop out of those early trials are 100% of the families that we work with. Highly stressed, low levels of support, high levels of stigma. And so the ability to use this literature is more limited than I want to admit based on the families that we work with. We needed their voice, we needed it to take shape and to address some of the other things that weren't in the traditional evidence-based parenting programs. The second thing I want to just say about this list quickly is when families dig into our academic literature, they have two responses. I'm happy to share with you. The first is, they're a little horrified about how we as academics talk about families. We say we don't blame families, we say we're kind of non-judgmental, and then you dig into our papers and it's all about parent psychopathology, parenting deficits. So really in a collaborative where your science is transparent to your consumers, there's a lot of processing that you have to do to really kind of think through, is this who I am as an academic, right? But the second thing that parents responded as they dug into the science with us is they kind of laughed. They said, Mary, you've raised 5 children. Do you ever go home and say, I'm going to have a positive parent-child interaction this evening? I'm going to create an atmosphere of warmth and security? No, you've come home from work, you're really tired. If you can get something reasonably nutritious on the table, you feel like it's a success. If you've only yelled a little bit because the dog has not gone out or the dinner was not ready, it's a successful evening. And so when families looked at this literature, they said, well, you know, that's interesting. And I believe you scientists that this actually matters, but could we translate this into a way that parents and providers could understand, work with, that applied with their lives? And this is probably one of the most innovative things around those collaborative methods is I wouldn't have done this. I would not have translated the entire evidence base around kids with conduct difficulties and what families could do into 4 words that begin with the letter R and 2 words that begin with the letter S. So no matter how much education, I wouldn't have done this. But what it did, and what I saw in these early trials, is this kind of work allowed the evidence base to be transparent. I no longer had to hide the intervention manual behind my back and do things to families. It was transparent. We were all understood what were some of the key components in families that could help kids be successful and where are the places that were really challenging, and we can work on that together. And for busy, overwhelmed providers, they could remember 4 R's and 2 S's if they practiced a little, right? So we made some other choices. Clinicians and parent advocates co-facilitate multiple family groups. There is a guided protocol so I can evaluate it, but there has some flexibility so that providers can put their own voice and choice into this. Parent consumers made a lot of contributions to the content. In New York State, we were key because of this intervention bill in helping our New York State officials start to credential family advocates as providers within clinics. Huge policy change that partly was kind of precipitated by some of the NIH-funded research. And so I'll let you have just a go at one of our parent co-facilitators as she talks about her experience in group.
Sometimes parents don't want to hear something from someone who isn't a parent. They may feel offended, or they may feel like they're insulted, or they may feel, but they may be more apt to listen to someone who is a parent and might appreciate what they have to say a little bit more.
Families can relate to us, and there's a certain ease and comfort with us that you don't find with a clinician or someone who has a title, I'm here for you. That's why I like to say I'm a parent partner as opposed to an advocate sometimes, because advocate is like someone who's fight, rah, rah. But a partner is someone who's partnering with you, help navigate whatever system or situation that you're going through.
We know the phases and the steps that they've been in because we've been in there too. And sometimes that helps the families be more open and willing to talk about what's going on in their surroundings.
So when I present that video, many people say, oh, that's fantastic, she's got a bridge to mental health clinics. No, we have partners within the mental health clinics. They're co-deliverers with us. And that was a huge policy change that we needed to make in order for this to be possible, to actually extend the workforce. Now, I would, in a different set of times, talk to you about how the Affordable Care Act allowed us to expand the workforce and hold promise for family advocates and peer advocates. I'm a little uncertain now where we're headed policy-wise, but that was the promise of the ACA, that we had an opportunity to extend our partners in the delivery of prevention programs and the delivery of intervention programs. And so I'll bracket that, and if you want to ask me later about policy implications, I'm happy to talk about those. So we thought we had the method, bringing people together. We thought we had the science. We thought we infused young people's voice, families' voice, providers' voice. And so now our job is to rigorously test it. And so these are the specific aims from the first R1 that we received from the National Institute of Mental Health to actually test. Does this intervention have any impact, short-term or long-term, for kids and families? What does it mean in terms of engagement, first and foremost? Can we decrease no-shows, lengthen the time? Because the evidence-based kind of literature says that unless you meet with families for a couple of months, there's almost no chance that you're going to change the trajectory that kids are on, and that's pretty short. So we had an experimental design. We were all over New York City, and within clinics randomly assigned 400 kids and their families to a multiple family group or services as usual. Everybody got something in this trial, and I'll talk to you a little bit about services as usual in just a few minutes. And so I'm just going to present some of the findings that we have published. I'm happy to refer you to some of these articles because I'll go fast because I want to get to scale up and resilience, as Bill told me that I should talk about too. You gave me a big job, Bill. There's a lot in this talk. So in this particular, I'll just talk about those 408 participants. 87% of heads of households describe themselves as female-headed. Do not be at all fooled that male caregivers and relatives and partners were also a part of kids' life. A third of parents were born outside the US. Only about half of our parents completed high school. You'll see a pretty even mix of African Americans and Latinos involved in the study. Young people split by gender, still in that elementary school, early junior high school range. So this is what we know about first rates of engagement. These bars represent each of the multiple family group sessions. We offered 16 of them in this particular trial, and the percentage of families that actually showed. And you'll see, I don't think I have a pointer, that probably the thing that we were happiest about in this graph, never did I expect 100% participation, but I was really happy at the last bar. At week 16, 80% of families came to pick up their graduation certificate. It's a small thing, but graduating from mental health care, I didn't think was such a good thing when we started this journey. 80% of families came to that culminating experience to applaud the success of their kids and themselves at finishing a stint of mental health care, right? Never perfect, and as a matter of fact, I had trouble in NIH review. What was I going to do when people miss sessions? I said, look, just proportionally miss less than standard of care. The half families that were randomized to standard of care, our data looks like every other piece of data in kids' services world. People come, they come for a couple of times. By week 12, about 15% of kids and families are there in services. Good for my intervention program, good for my journal publication, very, very bad for the kids and families that we were working with. The next set of questions had to do with impact. And again, we published a lot on this particular intervention, so I want to get to scale up, so I'll just give you a couple of ideas. We measured kids' functioning, their behaviors from their parents' perspective. By the way, kids are terrible reporters on their own behavior. Please ask their parents and their adults about whether they're getting better. Also, parents' perceptions are very difficult to change. Kids develop a reputation, perceptions, very stable. So we measured perceptions of kids' behavior, we measured family functioning, we measured parenting, positive family resilience and strength. There's a family strength scale, Bill, that I'll talk about if you like. We ask kids questions, teachers questions, and providers questions. So I'll just briefly talk a little bit about our multi-level models. And over time, what happens to kids and families as they journey through a multiple family group relative to standard of care. And this, again, this big, very busy table is published, but what you see is at least small to moderate effects around child disruptive behavior, impairment in peer relationships. We have a depression finding for adults, positive parent-child involvement, lots of movement on our core measures over time. This is just one model from our RRM, kind of runs random regression models that look at Connor's parent rating scores. This is essentially a checklist of, is your kid a pain in the neck? And what you'll see is the red bar represents kids in the multiple family group that over time parents reported that their kid actually was doing better behaviorally, the conduct difficulties were going down. The blue line doesn't surprise me. There is a lot of longitudinal research on disruptive kids. If you're disruptive now without serious intervention, you will remain disruptive. There's terrifying articles about, written by a guy named John Lockman that says you can pick kids out that are going to struggle in kindergarten. These are really stable behavioral patterns that kids have to and families have to get some help with. Or unsuccess reinforces more unsuccess, reinforces more unsuccess. Why did we think we got some of those outcomes in terms of the Iowa Connors and child conduct difficulties? We think it has everything to do with the actions in the family. This is just scores from a parent stress index, where you'll see stress in families that went through the multiple family group go significantly way down relative to stability over time. This is not short-term data now, this is 10 months from baseline. Stability, families are stably stressed in the services as usual condition. So what did collaboration give us? It gave us some beginning evidence that if you collaborate with young people, families, providers, you come up with something that holds more promise than potentially what we're doing in our current systems. That's great. And yet, when I ask kids and families, how'd it go for you? A lot of systematic ways they said, we love this. People were crying at the graduation, exchanging numbers. If I asked Bill, the provider, Dr. Powderly, when are you going to start your multiple family group again? Bill would say, wait, it's 2016? 2018 would be good. Not now. Wait, I need a break. I was so disappointed. I built it. They came. It worked as an academic. Why did Dr. Powderly say, I don't know, Mary? Because as an overburdened provider in a low resource system, what happened? First of all, you never had a no-show. Do not underestimate the fact that families showed up to these groups. And although we are well-intentioned providers, they showed up and they had problems and they had challenges, and we as providers were exhausted. So what that said to me is we had something that showed promise, but it was only beginning promise. We had to think hard about what's the next stage of collaboration, what's the next trial that we had to do to think about addressing poor Dr. Powderly's fatigue. Because he's a real part, providers are a real part of these equations. So we went back to the drawing board. What made a really good practice? Research evidence, consumer perspectives. We felt like we got that more right than wrong. But now, how could we line this up for practitioners within systems to scale it? Not in 10 clinics, but there's 134 clinics in New York City that serve kids. So this particular caption is one of my workers. We have a number of adolescent programs as well that we're testing, and he is jumping off a 30-foot pole. And so this represents our both pleasure and pride in our clinical trial, and then our knowing that we're not done. We have to go to scale. We have to think about creating something that we can actually embed in a system and address provider fatigues. And that came, now comes our scaling partners. In New York State, we were lucky to receive a relatively modest amount of support for something that we call the Children's or the Clinic Technical Assistance Center that brought together provider groups, family groups across New York City and state to look at some of the data like the 4 R's and 2 S's Family Strengthening Program and figure out how you would push that, support that, test that across the child providers in New York City and state. So we're currently working on 2 trials that, if you ask me honestly, or Bill, you said over a beer, you said we were going to discuss something, I would say these 2 trials scare me to death because of the methods and the questions they're trying to answer. And so I'll just give you some brief kind of updates on where we're at. We're working, thankfully, with National Institute of Mental Health funding on a trial that helps to scale and spread that multiple family group intervention. And then we're also taking a population approach to youth behavioral health and leaving clinics and systems behind and thinking about community strengthening rather than child or family strengthening. So in our current funded R01, we have used a hybrid effectiveness implementation design. And somehow we got both NIH and New York City and New York State to agree that we could randomly assign 134 child clinics. I know, scares you, right? To one of 3 conditions. Multiple family group as we designed it. Multiple family group plus a clinic implementation team. That's our experimental condition, and services as usual. What is that middle condition? What is this clinical implementation team? It is a team within a clinic that has permission to deconstruct, adapt, modify my evidence-based practice to fit within their setting. Now, those of you that have ever worked with evidence-based treatment developers, the thing they hate the most is when you monkey with their beautiful baby, right? We get to sell those, we have to measure fidelity. And as a matter of fact, I have a very funny colleague in New York when he talks about evidence-based practice. If you're a treatment developer like me, he puts up a picture of a beautiful baby. And he says, there's my baby, my program, it worked. It's published in JAMA, there it is. Right? But providers look at your baby, and then he puts up the picture of, I don't know where he found the ugliest baby I'd ever seen. That's how providers experience your baby. Lots of fidelity measures, way too long, not really tied and related to kids and families. And so in our second condition, on the ground, we're supporting teams to really look at what we designed and figure out how to help Dr. Powderly not be so tired. How to make sure it still met kids and families' needs, but it also met providers' needs and directors. Could they free up some resources, or could they negotiate some of the obstacles to make this service sustained in their clinic? So at this point, we have almost 1,000 kids and families enrolled in this particular trial. All 134 clinics signed up for this trial. And we're headed to almost 3,800 kids and families that ultimately will go through this trial in New York City. I think the work in clinics and systems are really important. And so know that I've devoted a lot of my career to what we call children's mental health services research, child implementation research. But the other part of my portfolio is how I know Dr. Powderly is from HIV prevention and care work in communities, and particularly in the 1990s when HIV became, it transformed from a kind of a plague around gay white men to an urban phenomena that was really tearing apart families, children, adults. And I learned a lot about community mobilization in an epidemic, both nationally as well as we do a lot of global work. So this particular large-scale NIH-funded study is called MAPS, Mobilizing the Adult Protective Shield. Right now, with existing data, I could tell you which zip codes of kids are burdened by mental health challenges. I can tell you where their families live, where they go to school, and they are not evenly distributed. So part of what sets kids up for behavioral unsuccess has everything to do with the enormous adversity that the kids and their families experience in community. Gun violence is just one of many, many exposures that kids have that sets them up for poor mental health. And so instead of taking addressing the consequences of poverty approach, which is our services, and those consequences are real, MAPS attempts to go at root causes. What are the structural drivers that need to be addressed within communities that can help kids be well, can support families to do their job as parents? And so this becomes, if any of you are trained in community organizing, a very structured collaborative method where MAPS pulls together parents who are raising kids in our targeted age range and helps them to look at stressors and strains on themselves as family, on their kids, and come up with potential solutions to buffer or directly address those stresses and strains. And I'm not going to have time to go through this very busy slide, but it's a very structured, multiple meeting, 12 meeting approach where we transparently share data with families around their community, strengths, needs, challenges. They also collect their own data around sources of stress and assets, and they create their own community mobilization projects. I think systems are incredibly important. What we do in mental health clinics, incredibly important. But in some ways, and now Enola, I'm getting old. In some ways, that's only part of the equation. The better way for maybe me to spend this last set of years in the academy is to think about addressing the toxins and the accumulated disadvantage that kids are experiencing that are shoveling them to our service systems, to our justice systems, to dropping out of school. And there's a science base on what those are. And NIH, I must tell you, those of you that are interested in structural interventions, they put out call and program announcement after program announcement. And my program officers tell me very, very few applications come in. Mostly because we also don't know how to review them, okay? But so as we think about St. Louis, and thank you so much for welcoming me. Could I just tell you that I gave this talk, I've been a dean 4 months, 29 days. Chancellor, I'm still counting. But it's a privilege to come to St. Louis. You drew me here with the strength of your science, with your commitment to kids and families and communities. You drew me because in some ways, and I don't know, Chancellor, maybe I'm just misquoting you, but I attribute this to somebody in your administration that says that St. Louis is big enough to matter, but it's also small enough to bring solutions. We can make a difference here. We can solve gun violence here, and collectively. So those are some of the issues that drew me. You have been warm, you've been welcoming. The Brownsville colleagues could not be better. As I look around the room, you're all in the audience. Equity issues matter. The reason we need structural interventions is because inequities around income, around opportunities, and this intersects powerfully with race, not only in St. Louis, but across our country. This is the next, I think, generation for kids' behavioral health, is thinking about what happens when you address some of these serious inequities. Do many, many of these challenges reverse themselves? Because what you see when you work directly with kids and families is their commitment to the same things that I was committed to when I raised my 5 children. They be well, they be educated. Those of you that have teenagers and you think they're never going to be employed might all now work. Right? Those same aspirations are shared. And so how to kind of really create the conditions, that's what I hope to be a good partner and a good supporter for you in St. Louis. So with that, thank you so much. And she didn't even give me the time.
This is a wonderful talk by the developer of the intervention, who's the principal investigator of this grant. And she talks about how it was developed in partnership using a community-based participatory research lens with caregivers who have had children with mental health needs. So it's a real from the ground up approach, excuse me, to developing an intervention that has evidence-based principles that are tied to the onset and perpetuation of behavior problems, but also that consumer perspective and voice. In order for you to become more saturated in implementation and dissemination factors, there are conferences you can attend, there are trainings, there are educational materials that you can read on this more. So I encourage you to click on those links in your free time and take a look at what's available to you with reference to moving the field forward with translational research. Okay, so that's the end of our modules and that's the end of our class. Have a wonderful break. I hope you had a very productive semester. And remember, your final papers are due shortly. If you have any questions, please feel free to reach out.